Now we're going to talk about defects that specifically can cause problems with gastrointestinal or fluid disturbance. We have cleft lip and cleft palate. So these are facial formations that occur during embryonic development. Specifically for the lip, it's about the 7th week of gestation, and the palate, the 7th to the 10th week. So as during that gestation, their fusing is occurring, and if there's any interruption in that fusing, then the fusion does not occur, and the lip is open and the palate is open. They may occur together, they may occur separately. The diagnosis is apparent at birth. You may have indications of it during fetal ultrasounds. The severity impacts the feeding. And I'll talk about that in a couple more slides. But here you can see variations in the cleft lip and the palate at birth. You have A is just a notch in the lip. Then in B you have and with A the palate is okay. So this child might do much better in feeding. With B, the palate is open, so that there will not be able to have suction occur when feeding. Same with C and D. So D, you don't have the lip malformation, but you do have the open palate, and for feeding, the sucking will need to occur in order to swallow. So these children, if they try to suck, they may excrete during through the nasal passages, and of course there's risk for failure to thrive or even aspiration and infection. So here's an example of how one needs to hold the baby and how special bottles can help form in those areas in order to acquire suction. The next picture is just how they do surgical correction, and they try to align with the natural seam of the lip, Z-plasty, to minimize retraction of the scar and to go along with the regular lines of the face. It's typically done at 12 to 18 months. There is an effect on speech development. Prognosis is excellent. Nursing consideration, specifically when it's first discovered, when the baby is born, that can be quite shocking to the parents. So it's important to support them and understand the complications, the feeding, and the prevention of further difficulties with the baby, such as failure to thrive. Another defect, esophageal atresia and tracheoesophageal fistula. So I'm going to go to this page so you can see. So it's just an incomplete fusion. The clinical signs are difficulty feeding, cyanotic during feeding, risks or aspiration. But you can see clearly there would be, if there's no attachment to the stomach, there's failure to thrive. If you have any, for example, with C, you have the stomach secretions, acids going into the trachea, so you might have risk for aspiration, pneumonia. Surgery is absolutely excellent prognosis for survival rates if caught early. Sorry, my voice is going. Okay. Hernias, protrusion of a portion of an organ through an abnormal opening. Really, I just want to talk about the umbilical hernia. Hernias, they can often resolve on their own. They're more common in boys than girls. But the problem is the incarceration or strangulation risk. So if the hernia is reducible, then especially in infancy and early newborn and infancy, then they hopefully will resolve on their own, and you just continue to monitor it. Gastroschisis and umbilical. I'm going to let you look at the pictures, the GI pictures, slides, and that just is, excuse me, so you know how the cleft palate during formation, it doesn't completely fuse? Well, the same thing happens to the stomach, and the stomach will fuse with the intestines outside of the lining. A picture is worth 1,000 words, so I'm going to let you look at the GI pictures. Here's a picture of the gastroschisis and the umbilical. So you can see the intestines, and the umbilical has the peritoneal sac. The gastroschisis, there is no peritoneal sac. So you have to keep the sac from drying. Can be related to other genetic defects. So you wanted to screen the baby for other genetic abnormalities. Hypertrophic pyloric stenosis. So this, the pyloric stenosis, the diagnostic evaluation is the child projectile vomiting after eating. The diagnostic evaluation is on due to history and physical exam, but you also have the upper GI screening. An ultrasound can be helpful. And this one, that projectile vomiting, is non-bilious in the early stages. Surgical relief can help the obstruction. And, oh, here's the other picture. The next picture shows the stenosis. So food is just not able to be passed, and then the body expectorates it. Okay, intussusception. This is an interesting intestinal disorder. Telescoping of one portion of the intestine into another. So let me go to this page. So you can see how the intestine kind of folds over itself. So you can understand what the problems are with this. You've got fecal matter stuck here. You can cause a lot of inflammation, but the classic clinical manifestation would be jelly-like stools, and so you want to. That's a classic sign. Then you might have diarrhea, anorexia, weight loss, sudden acute abdominal pain, tender, distended abdomen. Now, if this is happening, you've got this jelly-like stool, and then there's passage of normal stool, then that indicates that the intussusception has reduced itself. So then this child may not need any operation. I'm not sure what's going on with the slide, though. It kind of looks funky. So there's a surgical reduction. There can be non-operative reduction. That's successful in 65 to 75% of cases. IV fluids, decompression, antibiotic therapy may be used. And that's it for that piece. Malrotation and volvulus. Abnormal rotation. It may manifest in utero or may be asymptomatic throughout life. There may be bilious vomiting. So remember the bilious vomiting, or there's obstruction. So obviously if things aren't able to pass through, the problem is intestinal perforation can occur, peritonitis, necrosis, death. It needs to be diagnosed promptly, and surgical treatment is completed. Physical history, an abdominal radiograph can see the bowel. Bowel distension would be seen, and the rotation of the bowels can be easily seen. So this is surgery indicated to remove the affected area, and post-op nursing management is important for that. Anorectal malformations. So you have rectal atresia, a stenosis, so that's when an anal opening appears normal. No fistula, but it is a complete obstruction, and that requires immediate surgical intervention. So it appears normal, but there's nothing connecting. Persistent cloaca. So this is the embryological structure. The rectum and urinary tract separate completely by the 7th week of gestation. But this is a complex anorectal malformation in which the rectum, vagina, and urethra drain into a common channel opening into the perineum. So that obviously needs to be taken care of. So you may have vaginal, this female may have bacterial vaginitis, chronic infections. The imperforate anus with or without a fistula. So that means there's no there's no hole, right? So there's no obvious opening from the rectum to the anal exit. There's some lovely pictures in the book. Let's see. Yes, on figure 22.9, that shows the differences of female and a rectourethral bulbar fistula in the males. So if there's an imperforate anus, one needs to have that surgically repaired. Of course, diagnostic evaluation is based on physical finding and absent anal opening. Then, so you can see, oh, here's some of the pictures of the anatomy with the anal stenosis, imperforate anal membrane, and rectal atresia. Here's a picture of the no anal hole, and here's some examples of the persistent cloaca. So everything would be draining through the vaginal area. And that is a picture of a fistula, actually. Okay, that's that.